So to move away from breast cancer for a moment, that big picture I showed you of all the aberrations in cancer, there has been for about 15 years now a clue that a terrible disease called melanoma, the bad kind of skin cancer, that when it spreads didn't have any good treatments, that about half of them were driven. They had lots of mutations and lots of abnormalities, but the single driver appeared that it could be something called BRAF. It doesn't matter what, that's another piece of antenna wire from a receptor to the nucleus. And when the BRAF inhibitors were introduced into melanoma, we had a scurvy moment. So these are waterfall plots, and if the line goes up, the patient's tumor was growing when they were on the treatment. If the line goes down, the patient's tumors were shrinking. Almost every patient who had the BRAF mutation, who received these BRAF inhibitor drugs, had major tumor shrinkage. And that's a scurvy moment. That's what we're trying to do again and again throughout oncology. The problem with this has been that these responses are relatively short-lived, 6 months or so, and the tumor figures a way around. There's already now proof that if we add a second blocker in the same pathway, that will work. And by cataloging the ways these cancers are getting around, there is within sight the possibility of developing a cocktail of 3 drugs like we did in AIDS, where if you give one of the drugs, the tumor becomes resistant, but if you give all, or in that case the virus, but now we're talking about the tumor, that with 3 drugs we'll have an AIDS cocktail for BRAF positive melanoma. That tells us that it's not a crazy dream to think that we can be scurvy doctors in the 21st century in cancer, and that it's important to have access to clinical trials. These patients who were in this study only benefited because they were in a clinical trial, and before this clinical trial was done and the drug was on the market, there was clinical trials going on that made the people benefit even more. So there's benefits to patients. Now let's forget about clinical trials and just talk about oncology for a second in the spillover. So no sooner did that BRAF data come out than a patient walked into our place with metastatic anaplastic thyroid cancer. That's the top scan. This is a cross-section of the chest. Those black things are the lungs, and all those white things in the lungs are spots of anaplastic thyroid cancer. This is a cancer that still has no good treatment that's approved by the FDA and out there. It's a horrible disease. It's what killed William Rehnquist, the Chief Justice. And he was announced he was sick, and then 2 weeks later he died. This cancer goes quickly. But we knew that these cancers have the exact same mutation of BRAF in many cases that those melanoma patients had. And so this patient was treated with those same BRAF inhibitors, and within a month, the CT scan on the bottom was this patient's CT scan. So it's not just about clinical trials, and it's not just about finding subsets within the disease. It's realizing that in this particular instance, it was better to think about this anaplastic thyroid cancer as being BRAF mutated melanoma. It was a lot better for the patient that we thought about it that way. Here's another example. This is a man with esophageal cancer, cancer of the food pipe, spread to his lungs. And that's his liver scan on the left, and all those black spots are spots of his esophageal cancer. He presented with metastatic disease. This tumor had the exact same HER2 alteration that Dr. Slayman's breast cancer patients had. And it made sense to think about this as HER2 positive breast cancer of the esophagus spread to the liver. He was treated with 2 different HER2 blocking drugs with a little bit of chemotherapy, and that was 3 years ago, and his CAT scan today still looks like the CAT scan on the right. He has no evidence of disease. His tumor markers are fine. He's He's receiving Herceptin alone, and we hope that he's done dealing with what used to be a very rapidly fatal disease. And now we just heard from Italy that the BRAF mutation in hairy cell leukemia is a target, and that these BRAF inhibitors help that disease. So it's an exciting time to be an oncologist, but it's a time when you really have to read your journals and stay current and keep your feet under you, because things are changing very quickly. Another area, so Dr. Slayman in great detail and me in a much more superficial way have talked about the tumor and what's different about the tumor. We're revisiting in a really exciting way these days the interaction between the host and the tumor, and now with some scientific validity. People have talked about immune therapy for a long time, and in objective clinical trials it's been disappointing. But we now have a better understanding of how the immune system turns on and off, and how it has itself built-in breaks, just like cells and cancer cells do, and that in some cases tumors have expressed a switch that turns off the immune system. So the immune system, if it were to attack that tumor, would immediately be told by the tumor, no, you're not supposed to attack me, and they throw the off switch. That's the PD-L1 thing there. That's what the tumor expresses to turn off the immune reaction. There have been a variety of monoclonal antibodies developed to cut the brake cables on the immune system at various stages of immune activation, and those are now yielding relatively low response rates, real but low, about a quarter of patients having tumor shrinkage with melanoma, but these patients, it's permanent. When that happens, they are fine 5 years later. So it's a huge benefit to a smaller fraction of patients. And it's spilling over into other diseases, the most important one being lung cancer. These drugs are actually farthest along now in their development for treating lung cancer. It's a very exciting time. In the case of melanoma, the combination of these treatments with the BRAF inhibitors, the high response rate, short duration, lower response rate, long duration treatments is an obvious no-brainer, and those trials are opening now. Okay, now what about supportive care? Cancer is devastating, and cancer treatment can be devastating. I think we've got the devastating cancer treatment stuff pretty well handled. We can always do better, but that's not the toughest part of what we're trying to do in oncology. Where we have a long way to go is the effects of the cancer itself. We're developing all these treatments that stop cancer and convert it into a chronic illness, and we have to be really smart and develop better tools and for measurement and for treatment to restore these patients to their full quality of life, to undevastate this disease once we have it under control, because otherwise the longer we have people living, the more devastation we're going to see. Now, Dennis mentioned to you this notion that cancer is a normal part of aging. This is a map of cancer incident, this case breast cancer incidence around the world, and there are 2 points here. The first one is that different parts of the world are different colors. There's huge international variations in the risk of breast cancer. And when people migrate from low risk to high risk countries, their risk goes up. So that tells us the environment has something to do with a disease like breast cancer. But the other take-home point is that every single country everywhere in the world has a color. Breast cancer, there is a background risk of breast cancer, rate of breast cancer that's age-related, and will happen no matter how pristine our environment is, and no matter how much we return to the Garden of Eden in our lifestyles. And that means that there's an interaction between genetics and environment and luck in who gets cancer when. And the better we understand that, the better our primary care doctors will be armed to position our patients to have the lowest chance possible of seeing an oncologist ever in their lifetime, and we want to do that too, and that's a critical part of our healthcare system. So, to briefly summarize, the change in oncology is the most rapid it's been in history, and it's been because of the application of science and technology to the problem, and there's finally been a breakthrough. The ceiling's been shattered. But the faster a field's changing, the more important access to a very large cassette of very well-designed, the best clinical trials is. And the faster the field's changing, the more important constant education on the part of providers and patients is. And that's part of the picture of what our challenge is as well. And I'll stop there and turn it back to our moderator.
What can you say after that besides, wow, some really incredible stuff? I'm going to go home and try to explain some of that stuff tonight, I'm sure, and not do so well, but luckily we can all watch it on the web later.